past medical records and everything, because you are not terribly unusual, but usually the usual story is you find a cancer, you have some surgery, it's taken care of, and then a few years later you see it show up again. So with you kind of just snowballing everything at once,
Yes.
as a medical oncologist, that's why we think like medical oncologists rather than surgeons, because in some people it is a infection. I don't mean that literally.
Yes.
At the start, it's just that we don't know where all the infection is, so we use a lot of the things that we use assuming it's an infection and needs antibiotics. In you, we just know it's an infection and needs antibiotics, because there's no one place to cut out.
Yes.
Unfortunately, just removing your gallbladder or your appendix wouldn't do it.
Right.
And I know I talk in a lot of analogies, so you have
And that's
to.
okay.
I know you don't have a known gallbladder or
I
appendix.
know
problem.
exactly what you're, I
What kind
know
of
what
work you
you're
do?
saying. I work for a county auditor
Ah,
for our county.
auditors are popular.
Yes. I'm an assistant, one of many. So I have an interesting job.
I've been in administration for 20 years, so I have a lot of experience with auditors too.
I can imagine.
Yeah, they do their job. That's their job. That's right. And sometimes they instruct us about errors we have made, and please don't make them again in the future.
Oh, wow.
They're helpful. And I'm on a number of boards too, so we deal with auditors there. Well, so I have, and this is not a situation where we'll go in the past. But we'll ask you one question. So you're 51. When was this your first mammogram, or did you have a mammogram?
I've had mammograms in the past. Nothing has showed up, but with COVID, it was
Yeah.
due, and I've always had the fibroid cysts since young.
Gotcha.
Nothing has ever showed up, and with this, doctors and I just kind of forgot, or my regular doctor just kind of forgot about it, and I figured,
It's not an unusual story the last 2 years.
yes, so it's I have missed, so.
In fact, there are papers coming out now. We're trying to get our data put together, because we started March of 2020, but that was way too soon. But there's a lot of things in the press now and in our world of publishing about the delays in diagnosis that COVID may have caused. Because there's no question, the whole system kind of shut down. And it dealt with emergencies and COVID people in the hospital and so on, and we're going to go through that again now, where it's just not life as normal. So screening colonoscopies, screening mammograms, screening pap smears, that's what everybody's looking at to see what does the couple years after COVID look like, if COVID ever ends.
Yes.
I mean, I don't know.
It's gonna be here for the rest.
It's
for a
gonna be
long
here for a
time.
while, yep, that's for sure. And that's your port, that's right there. And the biopsy.
On the right side.
Yeah. So I don't know what you could have done. And that's why I said it's not, we don't like looking in the past either, we gotta look at the future. And I can see already that let me help you right down. I know, I'm gonna try to make this. So they radiated your hip. Did you
Yes,
feel any better yet from that?
I still have the pain, but it's nothing like it was.
Okay.
I'm able to move a lot better. I can lift my leg higher than I was able to.
Oh, that's important.
Yes, and so, but it's still there, the pain is still there, don't get me wrong. It hasn't taken away. But some days are better than others.
And the radiation is important for exactly that, pain relief. We sure hope you get pain relief eventually from some of the treatments we're doing. You know, I admit, this would have been easy to miss anyway.
It's very just.
Yeah.
I'm mistaken it for one of the little fibroids.
Yes.
Cause it's that small, or it felt that, like that.
Two things I'm glad about. I'm glad I'm not a woman. And I'm glad I don't have fibrocystic disease of the breast, because I mean, you're right. How can you tell? And the rule is kind of soft and squishy, benign, harder lump, but there's all that in between.
And I think I'm at the in between.
Well, don't.
Cause it didn't feel hard to me.
Yeah. Oh, it doesn't now. Deep breath. Yeah. So yeah, I don't. Said we have to look forward, not backward. Right. I mean, so I want to tell you a little bit of biology first.
Okay.
These down so you don't fall off, which is a bad thing to do in a hospital. You would think it'd be the right place to do that, but not at a cancer hospital. I'll give you another reason not to beat yourself up too much. Diabetes, cirrhosis of the liver, emphysema of the lungs, years and years of smoking, years and years of drinking, years and years of eating the wrong foods. 30 years later, someone walks in the door and says, you got diabetes. It takes a long time to get diabetes, but we can't pick up diabetes until we do a blood sugar on you. We say, oh, your blood sugar's up. Or until you walk in the doctor's office and they take your blood pressure and your blood pressure is high. How long have you had blood pressure? I don't know, but it's been a longer than yesterday. And that's true of all chronic diseases. In our world, that's certainly true. I'm going to scare you just a bit, but it's not meant to be scary, okay?
Mm-hmm.
It's meant to follow up on that build-up time, and really there's little you probably could have done. So, you can't see the dot I just made. In fact, I know I hit the table, but that might be it right there. But no, I know where I aimed, and I know kind of where to look. We can't see that dot I just made with CAT scans, MRIs, ultrasounds, mammograms, anything. That's way too small. It's like the dots on the wall. How many dots on the wall are there? Or most of them you can't even, you couldn't begin to count because most of them you can't even see. So we could do a CAT scan of the wall and still wouldn't answer that question. And that's our problem in medicine, typified by some of those other diseases. We don't know how to detect something you might have 5 years from now or 10 years from now. So we do a pretty good job detecting there's usually better things to look at. Don't want to go there yet. That 0. Most of our tests could see that 0. Well, this is about half that size. That O. When we get down to that period, nah. Even that period, Usually we find that period when we go in for that big zero and we find in the specimen, oh, there's another spot that's that big or so, because that's just a couple millimeters. That dot is hopelessly invisible to us until it gets to be something on that size. Now you say, well, that's not too long. No, it is, unfortunately. That dot, I don't know if you did this in grades or middle school, but I sure did. We had microscopes. You had to look at cells under the microscope and so on. You had to crank the microscope up to about 10,000 power or so.
Yes.
And they gave you a slide. You knew exactly where to look. Well, we don't have a microscope for your body, and we can't crank up the microscope too much. And that's the problem. So this is the scary part. It takes about 1 million cells to reach even that size. So you have to take, a 1 million of those dots I just made, or one smaller than that, and bunch them all together and end up with that. Because what's one cell? Well, one cell is that little thing that you have to crank up the microscope to see, and it's 1,000 times smaller than that dot, or 1 million times smaller. But yet that's how cancer starts, is in one cell, we think. It starts one cell somewhere. And now when you have a great amount of time, start at 1 and double it, count doubling. So 1, 2, 4, 8, 16, 32, 64, dot, 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 dot. 100,000, 200,000, 400,000. Count to 1 million and see how long it takes you. Now I'm going to impose another rule to you. You can only count every month. And now see how long it takes you to get to 1 million. It's growing. It's like money. It takes a long time to take a penny and grow into $1 million, right?
Right.
So the scary part is when we diagnose cancer, there's 1 million to 10 million cells present. And they've been there for a while. But when there was 10,000, they were invisible to us. In fact, probably most of the time when there's 100,000, it's invisible to us. You say, how can 100,000 cells be invisible to you? Well, you kind of have to go back in your mind and take 100,000 cells that you saw through a microscope and start doing that. And then finally, like most diseases, all of a sudden it's there and you say, where'd that come from? Well, it came from the same place a baby comes from, and it takes 9 months to grow a baby, even though about 3 or 4 months later, you know it, you know,
Yes.
you could feel. But a baby grows a lot faster than a cancer does. Now, there are some cancers, like leukemia, and I was a leukemia doctor for my first 10 years here. I've been here 42 now. But for my first 10 years, leukemia, acute leukemia, is one of those things that grows it doubles every hour. So that's why in leukemia patients, you hear the story, I felt well last week, and this week they tell me I might be dying. And if I don't get better immediately, I will die.
My ex-mother-in-law, before my husband and I, the girl's dad and I divorced, she was diagnosed with leukemia.
Acute leukemia?
Yes, so
That's a
very familiar
I know
with
that. I know that disease very well, and it doubles like this.
Hers was, oh yes.
Breast cancer, most colon cancer, they don't do that. They do like this. And that's the good and the bad. And what it means from the bad side of things is you can have it for a long time before we know we got it. So can I say almost for certain that sometime last year a mammogram probably would have been suspicious or abnormal?
Okay.
Because if we draw something like about this, maybe not, maybe something about like this right now, okay, that's about the size, give or take. Then say 2 months ago, and this is two-dimensional, you gotta realize these things are three-dimensional. It was like that, and then 2 months before that, it was like that, and then 2 months before that, it was like that, and then 2 months before that, it was like that, and 2 months before that, it was that, and then pretty soon we're back down to dot. Or worded another way in mathematics, so if 1,000,000 is 10 to the 6th, then 10 million is 10 to the, or 1 million is 10 to the 6th, and 10 million is 10 to the 7th, how many powers of 2 does it take to get to 10 to the 6th or 10 to the 7th? And that's about 14, 15, 16, somewhere in there. And yet after that, when this doubles, now it's this big, and when that doubles, then it's that big. So everybody says it came out of the blue, which nothing comes out of the blue, even a baby. And it's growing like wildfire, which it's not. Actually, it's growing at the same rate it's always grown. It's just that here to here, you didn't even know about it. Here to here, it becomes painfully obvious.
Right.
Why do I go through that long diatribe? Because way back here, preferably we remove things in this area, but way back here, long before you even know you have a problem, that's when it has the opportunity to throw cells off to the rest of the body. Now that either happens or it doesn't happen. If it doesn't happen,
Great.
then the surgeon goes in and removes this, and you are cured. Because that's the only place it is. It's like a bad appendix or a bad gallbladder. But if it has already thrown off some cells, then no surgeon in the world can cure you because they can't cut out what they can't see and don't know about.
Mhm.
That's when it's spread to your bones and probably the liver. It didn't happen up here, although the probability of it doing the bigger it gets is higher. It probably happened before you even knew you had a lump or could know you had a lump. And you can't do much about that. It's kind of like eyes and diabetes again. Some of the eye damage occurs in diabetes and some of the kidney damage occurs before you even are diagnosed with diabetes. In fact, a lot of times a person will go in because of vision problems or kidney problems, and the doctor will say, oh, by the way, you got diabetes. Well, when did they get the diabetic kidney problems? It was probably a couple of years ago. See how that works? And it's kind of a cynical, pessimistic view of life, but it's the way things are. And a medical oncologist that I am doesn't try to remove the primary. We try to treat the infection, so to speak, with antibiotics. We didn't have antibiotics until the 60s. So we had to rely on the surgeons getting rid of the source. And certainly in the 10s and 20s and 30s, there were people cured of cancer just with surgery because we didn't have any other treatment to give them. But in the 60s, we got our version of antibiotics, at first called chemotherapy. But later on, some things that, nobody likes chemotherapy, things that were a little milder than chemotherapy, like a pill called tamoxifen. Or sometimes in other diseases, other pills. Because we knew breast cancer was estrogen driven in a great number of people. Not everybody, but a great number. I didn't say estrogen caused, although about every 10 years it goes into the causative agents list, and then it comes off it, and then it goes back on it, and it goes on it again. The data's back and forth whether estrogen causes breast cancer. But it certainly feeds the cancer cells in a lot of women once they get cancerous. And so that's when we develop pills to block that feeding. And that's what you could think of chemotherapy as an atom bomb. Let's just drop an atom bomb, see what lives. You can think of a tamoxifen as kind of shutting off the feeding of the cancer cells by the estrogen. Both end up the same place, the cells are dead, and they can't divide anymore. Now, tamoxifen was very good for about 20 years. Now there's a pill, there's other things called aromatase inhibitors, because in a postmenopausal woman, most of your estrogen is made in your fat cells, and your adrenal glands sit on top of your kidneys. Tamoxifen doesn't stop production, it just sits on the cell so it can't see the estrogen, but the aromatase inhibitors actually stop the production of estrogen by those places in your body. And Femara is one, and Arimidex is one, and then there's another one called Aromacin. And that's what replaced tamoxifen as kind of in first place. And that won't change. So for about 40 years, our choices were hormone blocking agents or chemotherapy, and still are. Now the ads you see on television are something we've also been looking at for over 50 years. Well, how can we just turn on your immune system? Because your immune system ought to kill these cells off. Why doesn't it? Well, they're smart cells. Sometimes they have things on them that say, immune system, I'm really a part of her, don't mess with me. Or sometimes they secrete things that block your immune system, and no amount of immune therapy is going to overcome that. So there's a lot of drugs being developed for that. Some of them have been on the news. Usually when those drugs come out, they're approved for like lung cancer and melanoma and difficult cancers. For the cancers that we don't really have other alternatives for. We're doing a lot of investigation in breast cancer with those drugs now. You haven't seen the end result of this yet, because we start in the group of women with the worst, most aggressive one called triple negative, that are not fed by estrogen. We really don't have anything to give them other than chemotherapy. So that's one area we're looking at, immune therapy and drugs that block the block of immune systems. I don't know, I've been through 5 rounds of immunotherapy in my career, and there's always a great deal of hype. This time it might actually be real, because it does work better than anything we've done in the past for certain cancers. The other ad you see on TV every single night is the gray line I call what is chemotherapy, because chemotherapy works by stopping the cells from dividing, by killing them, literally. Actually, it just turns off their metabolism and says don't grow anymore. So that Ibrance you see on television every night, or there's another, what happens in our world is it used to be chemo version 1, chemo version 2, Tide, new Tide, all those things, better adriamycin, better Cytoxan, less toxicity, and so on. That world's kind of come to an end in the last 10 years, because we've probably gotten as much mileage as we can out of chemotherapy. So now you see the drugs like Ibrance coming along, which I'm not sure it works. I'm not sure it does work. I'm not sure if it's chemo or not, because what it does is, I'll pull it up. Unfortunately, estrogen is the major, but just one of about 20 signals to your breast cancer to grow. So the analogy I use there is lights off, lights on. That simple. Now picture 20 switches up here, and all of them had to be off to turn the lights off. Well, first of all, I don't have enough fingers to do that. But let's say I managed to do it. Then the lights might stay off. But instead, let's say I could just get my hand on 5 of them, and I flipped those 5 off, but another 3 went on. And then I reached over this hand, I turned those 3 off, but these 4 went on. That's what cancer is, and we're finding more and more about it. There's a lot of signals that go on to these cancer cells. They're different in different people. But it explains a thing a question we've always had: why don't hormone therapies work in everyone? They should. That's what they're designed to do, shut off the estrogen feeding. Well, because it's just one pathway to the estrogen, and there's 4 or 5 other pathways with about 19 other different different molecules. And the cancer cells, pretty smart, they learn to acquire those molecules, or they're the ones that hang around because they have those molecules. It's kind of like weeds in a way. You put out the best weed killer, it kills off a patch, but then they come right back and you say, how'd that happen? So you get the second best weed killer and the same thing happens. They're really smart, these cancer cells, and they're not all the same. See, we lump you in with all other estrogen positive people, but you're not. You're you. And your cells are probably totally different than everybody else's cells. So that's what's called the field of personalized cancer medicine, which sounds great, but it depends on how many drugs you have to personalize with, and those all have to be developed and approved by the FDA and so on before they can be used. So I just described 2 ways. One is kind of, I'm an oncologist in Austin, here's what I would do. It's a standard FDA approved way, and it's what the rest of the country does. I didn't say, by the way, we formed a national organization called nccn.org, the National Comprehensive Cancer Network. It writes the guidelines for how to treat breast cancer, and we have for 25 years. Sloan Kettering, Mayo Clinic, Dana-Farber, all the places in the country contribute to those guidelines, and that's what we expect people to do. Those are the standards. And then there's this world, which is the experimental research study world, was, yeah, but what new ideas can we dream up? And how can we test them and maybe someday get those on those standards? And we have a foot in both worlds, as does a lot of places other than us. So that's kind of the world we're moving towards, is truly personalized therapy. You are getting personalized therapy, the first one that came out, which was hormone blockage of estrogen positive breast cancer. That's what you're on right now. Can't get more personalized than that. Before that, the only thing that beat that was taking out your ovaries, because that guaranteed removed your estrogen. But since your ovaries are kind of suffering nowadays, we can use drugs that are directed against the other sources of estrogen. Right? You have ovaries, don't you?
No.
Yeah, you have. They're more than suffering, they're dead.
They're
gone.
They're gone.
That's right. So your only source of estrogen production is those other places. And that's what Arimidex is designed to do. Now, I'm talking another analogy. If you had a sore throat, maybe you're running a fever 104, and we gave you some penicillin to take, and you went home, started your penicillin, and you took a temperature every hour, because you're a religious type of person, you really wanted to follow your temperature. Not religious, obsessive. And you called it 2 hours later and said, my temperature's not down yet. Should I stop the penicillin? We'd say, no. Everybody's mother said, finish the prescription before we make a judgment about it, right? And that was usually 5 or 7 days or something like that. Well, that's where you are right now in this circumstance. You started the penicillin, except in our world, your fever doesn't come down right away. It takes at least a month or 2 or 3, which is very frustrating to everybody, but these aren't bugs, and this isn't an antibiotic. See, the antibiotic world, things work pretty fast in.
Yeah.
This takes a little longer time, if nothing else, because we're killing off a lot. I don't know if we're killing off more cells than you kill off bugs in infection, but they're certainly more sensitive in infections most of the time. HIV, some TB, HIV exceptions. But the principle's exactly the same. You started an antibiotic for your infection. Now we have to see if it's working. And it's the #1 antibiotic for ER positive disease. So the thing I knew when I heard that was I certainly was not going to come here and tell you stop taking it. That would be like stopping the penicillin the day after you start the penicillin. And it's not on TV for no reason. It's because it actually works in a lot of people. Goals in you. Make your hip feel better. Now we might fight with the radiation oncologist eventually about was it our pills or your radiation treatments, but who cares? It gets better, who cares? And then you have x-rays of other parts of your body that we can see if it's actually helping you. And that's how we do. We expect things to get smaller and go away and disappear and stay away for a long time. And if that does not happen, then we go into that other world of either research study, why didn't ER block work in you? And we start looking down that pathway. Or we go to the other ad that's on TV every night, and it's another hormone blocker called Faslodex, which is an injection combined with another pill. Same category as the one that came out first. And that's what it's FDA approved for, because some people, it works when the first one didn't. Or the word that nobody likes to hear is chemotherapy, which of course we do have a lot of experience with. And chemotherapy has worked very well for years. It's just different. It tends to cause more problems, like the number one drug we use, adriamycin, can damage your heart. And so the reason we've switched a lot to these other approaches is because there's more of a pushback than ever about the toxicities that chemo can cause. Taxol, another very famous drug from the 80s, originally came from the western yew tree, home of the spotted owl. So the poor owls didn't like people cutting their trees down to make Taxol. Now it's synthesized, but it can cause a neuropathy. When you look at the ads on television at the very bottom, they usually say something like, this drug can cause lowering of the blood counts, can cause hair loss, can cause a fever when you get an infection, can lead to this, that, and the other. You start saying, well, gee, that sounds a lot like chemotherapy, which it is, but it's milder chemotherapy, I would say. It's milder. It's not called, like I say, I don't know whether to call it chemotherapy. It has some of the same side effects because it has the same mechanism of action. Now, I just drifted over into the drug you're not on, I think, and I'm not sure completely why. You started the Arimidex, right?
Yes.
Anastrozole.
Yes.
And there's Femara, which is letrozole, and there's Aromacin, which is exemestane. So those are all three penicillins, so to speak. And Arimidex was the one. Actually, I think Femara came out first, but it was predominantly a Canadian drug, and so when Arimidex came out, we chose Arimidex. But either of those are good. You started that, but they did not put you on probably because of the radiation, the other drug, Ibrance, which is it's part of the same television ad, only they use Femara in there. Femara and Ibrance, because Ibrance gives the hormone treatments that extra kick of blocking the turnover of the cells too. So the hormone blockers block the stimulation, and the Ibrance actually stops the turnaround. And so those two together work better than the hormone therapy alone. Now, that may not have been done because you were getting radiation, which can also affect your blood counts. And I didn't want to give you too many things at the same time. But that's the way treatment has changed over the years, is that we don't just use the hormone over the last 5 years. We don't just use the hormone blocker by itself. We use it in combination with these other drugs. And they're not experimental at all. Ibrance is called palbociclib. And its next drug was ribociclib, so you'll see that on the TV. And then the next one was called abemaciclib. And so there's 3 different aromatase inhibitors and 3 different drugs that kind of block, and they're all used for different when you go on that, it's a pill you take 21 days, every 28 days. So you kind of take it almost like chemotherapy. And it helps make the hormone therapies work better. That's probably
Okay.
the best way to word it. Now, after the equivalent of 5 days of antibiotics, which for us, unfortunately, is 2 to 3 months, we do all the tests again, see if they're working, then come to some conclusion. And if they're working, you continue it. And if they're not working, then we go either the chemo route, the second hormone therapy route, or the experimental route. But that's putting the cart way ahead of the horse right now, because if they are working, you just stay on them forever. And as the ad says on television, some people have done very well for a very long period of time. When I say working, I mean, again, not only does that get smaller, but the liver improves and your bones don't hurt anymore. That's our goal. I mean, I don't know 5 years from now or 10 years from now. The world is changing so fast in this area. But that's why I said we do think of it as a chronic disease like diabetes, high blood pressure, and so on, where you might need treatment all the time, or there might be large breaks between treatments, between the need for treatment. But there are people who really are still around 10 years after they have metastatic breast cancer. So it's not an unreasonable goal anymore, and longer. Back in chemo days, when we gave chemo to breast cancer patients, about 75% responded. 75% of people responded, and about 25% of that 75% was complete responses, which means it went away. And 25 of that 25%, it went away forever. So we know it happens. And the hormone treatments have about the same story as far as when they work, they really work. And in you, it's not going to be hard to tell if they're working. How you feel, what we x-ray, and sometimes some blood tests. And it's not a soap opera story, but I mean, it's true that this world is changing so fast that I don't even know what we're going to do in 5 years from now. I suspect by that time, after we use our best treatments, immunotherapy will probably be the maintenance solution of some sort to try to boost your immune system to get rid of the last cancer cell.
Okay.
That's the problem with the immunotherapy argument, is it probably, these cells are smarter, bigger, those survivors, so to speak. And people's immune systems, except for a few diseases, probably can't deal with that, but they probably can deal with this down here. So you need something to move it that direction. I think they started the Arimidex just to kind of get you on something that wouldn't interfere with the radiation treatments, get you going, so to speak. But Arimidex by itself is not the standard of care anymore. It's in combination with Ibrance.
Okay.
Ibrance is a pretty simple pill. It comes in 2 doses. We calculate it, and we calculate what your dose should be. It's FDA approved and covered by insurance companies. I mean, we know just about everything we need to know about Ibrance. It's kind of like chemotherapy in that at the start of things, we have to monitor your blood counts. We do that on chemo patients all the time. And we adjust the dose depending on how low your blood counts go, but also how quickly they bounce back. That's the chemo story too. It just is not, it's not the same degree of down and slow recovery that chemotherapy can be. And Ibrance is called palbociclib, P-A-L-B-O-C-I-C-L-I-B, and we're going to give you information about it.
Okay.
So that's the only thing I would add, and it's not experimental, it's not research, it's standard of care, first choice.
So, Dr. Walter, we're here for a reason, and to get this second opinion. Everything that you see in her chart, we have had to push. It wasn't any recommendation of the oncologist because they gave her the stage 4 with medicine, told her she has 3 to 5 years to live and good luck. We're going to do palliative on you.
Yeah, I used to know that. I don't know it anymore.
Yeah.
That's why
so-
they are no longer.
That's why we're here, because it took us a while to get here. We intentionally, strategically came to the ER a couple of times in hopes to getting quicker. And so,
That's how the x-rays got done. Yeah, I
Yes.
wondered that, because you
yeah.
can't have those done without a doctor seeing it, yeah.
Yeah.
Yes.
The PET scan that we just did, the stories is, even though we're in Austin, they don't see a lot. And basically they washed her hands with her and not gave her any options or any choices for her to decide as a patient which route she wanted to go in. So your explanation, we understand more. And I actually feel more comfortable
Yes.
today than I have fighting with the oncologist. And as a nurse, it was very frustrating to see a doctor shut down when we all have an oath to practice medicine to the benefit and the best of our knowledge for our patients in science.
Yep.
And that didn't happen. So this is good news for us.
Yes. Very good news.
We're not rocket scientists. This is not that complicated. It should make sense. And I try to explain things in a way that makes sense.
You have.
And I gave up knowing the future a long time ago. When I was a leukemia doctor back in the late 70s, I saw 18-year-olds that looked well that morning and were dead that night. And I said, wait, that shouldn't happen. This is not leukemia.
Right.
And, this is a very treatable disease. No question it's treatable. In fact, I'm going to show you something that you can go to. It's very treatable, and I'm going to cheat. I'll warn you in advance, I'm going to cheat. Let's say I told you you had high blood pressure and you said, how long am I going to live? You know what I'd answer? Or diabetes, it can be either one. I would say, well, I'm going to give you these pills. If your blood pressure comes down, you might live forever. If your blood pressure doesn't come down, then I have some second other pills to try. And if they don't bring your blood pressure down, we got a problem. Because your heart gets strained and your kidneys get strained and all these other things. So the cheating is, we use your response to our treatments to answer your question. Now, we still don't know the future, but I describe the people who go into what's called a complete remission. We give them some treatments and pretty soon we can't tell anything's going on. And you're not going to be that hard to know the response in. And then that fine-tunes our guess. Did it come down to here? Which that may last a long time, years. Did it go down 50% but kind of leveled off? Well, that's not as good, but stable. You can't knock stability. Or did it not even respond at all? In which case it's like the blood pressure. We got a problem. But in this circumstance, we have second and third and fourth. And we got oodles of more blood pressure medicine. It's just a question of what to use at what time. And what these pills have done is they force the question of when do you use chemotherapy? Because the pills that have come out can work as good as chemotherapy does, and why put a person through all the toxicities of chemotherapy if you can give them pills that work just as well with a lot fewer side effects? You see, that's so chemo is not written off the table. It's just saying, look, we got better things to try first, and you've already started the best of them, so let's see how it does. So here, this isn't where I was going. This is where I was going over here. Here's how we think in research world. So this is our research list, basically. This is everything, and it's not that page. It's precisely 14 pages long. But we divide the world into HER2/neu positive, you're not HER2/neu positive. That's another gene that drives breast cancer growth. You were tested for that, you're not positive for that.
Really?
HER2/neu, did someone tell you you were?
Yeah.
Did I make a mistake?
No, not you. Them.
All right, just a second, hold that. Here's hormone positive. Here's the immunotherapy stuff we're doing. And here's that whole new, well, actually all this is a little bit, but targeted therapy. So do you have these mutations? Then there's drugs in development that kind of hit those mutations, just like the ER one. Here's triple negative, and here's for people that have brain mets. So that's how we organize our thoughts. And then we have trials that are going on in each of those. So if you look what you are here, just a second, because I'm going to come back to that.
Okay.
That's a big, I don't know what's going on here. This is a little crazy.
Has a brain of its own.
It sure does. I'm going to show it who's boss here. And go somewhere else. I'll go over here a second. Because if I made a mistake, I certainly want to know. HER2/neu negative.
You're negative.
I'm negative.
Yeah, I that's like a big mistake. If I was wrong there, it's a big mistake because there's whole drugs that target HER2.
You were told that, but we're seeing that it's negative. Okay, so take a deep breath.
Well, this is the bone biopsy. That's the one we have.
Mm-hmm.
And there you can see ER is 3+, PR is negative. That's another hormone. ER and PR we've always kind of put together, but some people are ER positive and PR negative. Most of the time it's ER positive, PR positive. Doesn't matter, we don't have a PR positive drug. We use it as a sign of hormone sensitivity. But yeah, HER2/neu negative. And that's the only biopsy you've had, right?
Correct.
Yes.
Yeah,
Yeah,
only
okay.
one.
Oh, thank goodness I did. Boy, that you just made my heart skip a little bit.
No, 'cause that's what they told me. I was HR positive.
No,
Her positive.
well, you just we may
Now
have
we know
we might
I'm
have
not.
to double check that. I mean, we can run this test too.
Yeah.
That's like super important because as many drugs as there are for the hormone side of things, we're about 3 or 4 deep on HER2/neu positive drugs now. And they're the other thing you see on both billboard signs and television and so on. That's why. So you can do this yourself, or you can do it if you want to. nccn.org. I'll tell you, I've been very fortunate to be MD Anderson's first chair of the board of this organization for the last 3 years. And that's what we do, is write guidelines. And so I'll show you. You go up there. There's a patient version of one I'm going to show you. nccn.org. And they are the consensus guideline writers for the field of oncology. ASCO does a little bit, but this is the one that the payers use. This is the one that CMS uses. And it all started 25 years ago. So you can go guidelines by cancer type, breast cancer. Okay, and here we are. So you'll get this 200 and, well, yours probably won't be this long, but ours is 245 pages. And here's all the organizations that contribute to them. It's the who's who of oncology, I'll tell you. And then here's who the representatives are. One of our breast doctors is on that list. And then we go through all the different, it's very, if this, then here.
Like
if
an
this, then here.
algorithm.
Yeah, it's all a bunch of algorithms. So you're down here in, most people start out again with lumps and bumps that are cut out. So that's what we call adjuvant. And then if we go down to recurrent disease or newly diagnosed disease, that's where you are here. You have the test study, figure out what the problems are. You some people we still do surgery on, but in you, not, I can't say never, but not right now, because surgery on your breast wouldn't do a darn thing for your hip. Surgery on your breast wouldn't do a darn thing for your liver. For any other place in your body, it's just not, it makes a lot of sense to get everything out, but it doesn't affect you at all. And so here's the ER negative ones, and here's the ER negative and or PR positive, ER negative and ER positive. Just a second, I'm getting there. These things are kind of interesting to scroll through.
So while you're getting there, are you seeing spots on her liver as well that you're mentioning the
Thought they
liver?
described the, let me go back, because they described something there. See, here's all the HER2 stuff. And that's why that's so important, because it drives all of our guidance.
Sure.
HR testing. I know the links are faster, but I just didn't get the right link.
It's okay. Education is great.
All these principal sections. These are all the chemo regimens, by the way. So it literally covers the entire kitchen sink of possibilities. And even this group strongly believes that when appropriate, the right treatment is, we should always think of, here we go. Systemic therapy for ER and or PR positive, that doesn't mean negative, it's ER dash.
Okay.
Recurrent, unresectable, local or regional or stage 4 disease.
Okay.
So that on whatever, 79 is the page I was looking for. And first line therapy, preferred. We always list preferred and then we say, but there's other things too. So here, aromatase inhibitor, you're doing it. Plus CDK4/6 inhibitor, abemaciclib, palbociclib, or ribociclib. Category 1s means randomized clinical trials. It means there's evidence that those are better than anything else. Up until a couple of years ago, maybe 3, it would have just been that. Okay. Then there's that drug I mentioned called fulvestrant, and that also has a combination with a C4K inhibitor. That's either abemaciclib or ribociclib. Ribociclib is what's on the TV ads right now. Abemaciclib is another one. And then so basically it gives something that affects the estrogen receptor. That's the first line treatment. Then if that doesn't work, then there's all these other things, and then these are very old treatments, progesterone. First treatment we did for breast cancer after removing your ovaries, strangely enough, instead of removing your ovaries, was high dose estrogen, which sounds completely crazy, but if you go back like 70 years, that was it. And it works, just causes a lot of side effects. And then here's all the chemotherapy options. It's for HER2 negative, but yeah. Okay, now you asked something else. So that's nccn.org, and you're welcome to visit, because we tried to make that, we purposely make that available to everybody so that you can see that I'm not lying to you. That's what truth is. All right, now imaging. So I have mentioned your liver, hepatic cyst. Yeah, there's a 5.8 millimeter enhancing lesion in segment 3, which metastasis is suspected. And they do talk about metastatic disease to the pubis, bilateral pubis,
Yes,
which is not news to you.
right.
And then they talked about this most likely a metastasis, unchanged since June. And I actually looked at that earlier. Yeah, also, I don't know what my CAT scan of the liver would show. I've never had a CAT scan of the liver because I've developed this theory about medicine that you're healthy until you get tests done, and then all of a sudden
Yeah,
there's
all of a
something
sudden, right?
wrong with you. Yeah, you're healthy until you see a doctor and get some tests done.
So, just a couple of questions for education. So, if it's possible suspect, do we look into biopsies?
Not needed.
Like,
No,
okay,
we just, if she hadn't had her hip biopsied, we would do exactly that.
okay,
But we don't have to biopsy everything, otherwise you'd start feeling like a pincushion. So they think this is probably a cyst here. This is your liver.
Okay.
There's your spleen. Let me see, that's your stomach. Spleen's over here. Or, yeah. One of those is your spleen and one's your stomach. I'm beginning to wonder if that's your stomach because that's got air in it. So they just pointed out this small little area here. It is not a liver riddled with cancer. Now, if we go to the dye version of that test after they give you the injection, so that didn't take up dye. That's why that's a cyst.
Okay.
And that one I don't see on the dye study. It's probably that there.
Okay.
But I don't know, and you know, if everything else goes away, that'll go away too.
Okay.
perfect.
It's the antibiotic theory.
Okay.
Right. Well, we were told about the cyst. We weren't told about the suspect of that. So this is good that we're at least discussing that. This is
And
great.
Here's the PET scan. So PET scan is what we say non-specific. It's very sensitive, but it's a non-specific test. And what I mean by that, it shows all sorts of things, and some of them aren't even relevant, but they scare a lot of people. Trying to get to the front facing one. Go to one of these colored ones over here. Well, so this, in a PET scan, this cuts you off at the belly.
Mm,
Well, I'm looking for that version, but one that scrolls, and not there. See, when I scroll, it just magnifies it.
Right.
So let me go back to fused legs, fused legs, fused legs, fused legs, whole body. This is your outside PET scan too. Yeah. I tell you, I'm lost as to why just the bottom half is showing up and I can't get to the top half. This is your outside PET scans. But they did them in a way that instead of looking at the whole you standing and facing me, they're in slices,
Right. I see that. Yeah.
which
It's difficult. A little more
which
difficult.
doesn't allow me to scroll either. So
Do we need to repeat that so it's easier to look at?
I don't think your insurance company like that.
Oh, we don't mind fighting again. We fought for this one.
We'd have to go to somewhere else, because this, the gentleman that was doing this, he said that they did it in sections because their machine was an older type of machine.
Yeah,
Oh, you should have just
And-
got off the table.
Well, I didn't know what all was involved.
yeah, so when we do a PET scan, we have a nice picture that basically, it's like a bone scan. I can see the whole person and then I scroll down through it.
Right.
That's why I was having problems. So I think I don't remember what the PET scan said, but I was going by the CAT scan. So this is just CAT scan.
Okay.
This is the PET scan without the nuclear material.
Right.
So it's just CAT scan.
Here's a copy of the PET if you need it.
Yeah, and I think let's see. Comparison findings and diagram, yeah, so the multiple fluid attenuating foci in both hepatic lobes up to 1.9 and 2.1. So that could be cis. Right X-ray node. Non-FDG avid hepatic hypodensity is consistent with cis. Okay. Take back the liver then. The breast has been there long enough that they see a lymph node under the arm and then the bones.
Okay.
So that's it.
We were also told that she has a small new spot on the left shaft of the upper extremity of the leg. Is that showing a spot?
Well, well, no. But, we published a paper about 30 years ago. That sometimes when people start treatments, we see these reactive changes start showing up and it's actually healing rather than growing spots. So that's another thing where time tells how the whole picture is going and then how that one's doing. So, who's your insurance company?
Blue Cross Blue Shield.
You probably have a mail-in pharmacy like we do then.
Yes,
Yeah,
but I don't use it.
You will for the eye brands because it's
Really?
Someone told me $5,000
Oh, shoot. Okay.
some ungodly number. So yeah, we have to go through that.
Okay.
Do you have refills on your Arimidex?
Okay.
On your Anastrozole?
I have to check.
We'll check for that too.
So if we can talk about pain control too. She's on a fentanyl patch, but her patch, this will be the first time that it's fallen off. And her memory is not the same where it is. So just concern is like putting it on every 3 days. She was given Dilaudid as needed for breakthrough pain.
Can I tell you another thing we have here? We have some very good pain doctors. And that's exactly what they do.
Okay.
I can tell you what we believe in. It's kind of like she's describing. We believe in a chronic level of pain control that brings it down to not too bad, and then breakthrough pain when you need it. And usually that's a form of morphine, like MS Contin or so. And then the morphine is, because all these are basically derivatives of morphine anyway. They either metabolize to morphine or they're just another form of morphine. And then breakthrough morphine when you need it for immediate relief of pain. But they are experts in that.
Okay.
And I can set up an appointment
Yes, please.
real quickly with them.
Please.
And then they'll look at all this and they'll come up with kind of a cookbook to handle your pain.
Okay. I would like that.
Yeah, so that's kind of, I can prescribe. I certainly have a license in the DEA to do that. But it's like, I learned a long time ago. I don't like prescribing heart medicine because I'm not a cardiologist. Would the cardiologist prescribe chemotherapy? No. Now, pain is a little different because we deal with it all the time, but we still have specialists in pain here. And they'll give you the right prescription,
Okay.
and they'll give you someone to stay connected to.
Okay, perfect.
Yeah, so that's kind of, it's not a total evasion, it's just,
Sure. And one last question, just, we were also told that she did have some spots in her vulva.
on the PET scan, on the CAT scan.
Originally when we first went to this doctor. So I'm just kind of curious, since we're finding great things out today, if that was even indicated. I didn't see it, but I'm not a doctor.
I don't either. There's spots on the symphysis pubis,
Correct.
which is another bone,
Right,
but no, nothing described there at all on our CAT scans.
right,
And even on the PET scan, they didn't mention anything there.
right.
So we're kind of funny, in a certain way. We have all sorts of double checks going on at this place. It's all the good news. It's almost impossible for me to practice bad medicine. Everything we do have to be signed off with somebody, and we pioneered advanced practice nurses. I was actually on service in leukemia when the first one was here in late 70s. And we have the advantage of having PharmDs. And we have 6 of them in the breast clinic. And the PharmDs are the ones who are experts in medications. And they literally, I can't prescribe a chemo agent without them signing off on it. They check the doses right, they check the body surface area, they check the calculation, they check that it's being used for the right thing, and so on and so on. While it may sound like overkill, it ends up translating into some pretty good care. In a private doctus, or in a private office, or in a lot of other places, you're highly dependent on how smart I am on whether I don't make mistakes. Well, again, I know I'm a human being. I've made quite a few mistakes in my time. But we put so many backups behind that you can't, I describe it, you can't work here if you are not used to the idea that there's a lot of other people watching you. There's the other doctors in breast. Heck, even our surgeons and radiation doctors will call me every so often and say, Walters, why are you doing that? Or they'll tell me ahead of time and say, here's what we think you should be doing. I'll say, yeah, I agree with you. So, I mean, that's the checks and balances system that we have in place here. So I'm going to do what they normally do, but my PharmD's out today. So just a second here. I have to go over here. I like Epic, but not too much. I consent. There we go. We put it in the tab. And this will be for. We consent. I'm amazed. Still, amongst all those national institutions, we're one of the ones that consent everybody for any chemotherapy. A lot of places rolled it up into the front door consent process, and we don't think that's right. So we're in the breast clinic. Systemic therapy consents, and here's the drug. Like any of those. 5/16. Oh. close this out and open the encounter. Those are all different encounter numbers, not her patient number. Then I'll go back to my consent. That's why none of those matched her. And then I'll go back down here again, press center, select, yes. Okay, I am. Breast cancer. Palo. Consent being translated to patient. No. Consent by patient. Yes. Okay, what they would do, that now I'm going to do, you have the right as a patient to be informed about your condition and recommended chemotherapy. They use that term. I told you it's kind of gray, but to be used so that you may make the decision whether or not to undergo the treatment after knowing the risks and hazards involved. This disclosure is not meant to scare you or alarm you, although it might a little bit. It is simply an effort to make you better informed so you may give or withhold your consent to treatment.
So, Dr. Walters, while you're looking through that, the lymph nodes, they're very important to the body, and since there's a spot in there, what is your thought about that? Is there anything that we can do to
So
that?
if she was the kind of person that had the cancer first without any spread, we would have called her stage 2 breast cancer because it started in the breast and it spread to the lymph nodes.
Right.
They would have done surgery for, well, actually for the last 30 years we've given chemotherapy first, then do surgery. But another option would be to do surgery first. They remove the breast and or the lump. They take out the lymph nodes, how many there are obvious. You don't leave lymph nodes in. And then you come to see me about what we should do to prevent the cancer from coming back. Or is another wording, to treat the disease that we think might be out there but can't see. Now, she asked a good question, and I'm going to answer it a certain way. We don't care about those lymph nodes. I don't mean that literally. But they're part of the systemic process now, and you've got other areas that take priority over those lymph nodes.
Okay.
So it's the same rationale why you don't have breast surgery done now.
Okay.
You also don't have lymph node surgery done now because it's a systemic disease. It's stage 4. It means anywhere outside the breast. And if the treatments work there, they usually work everywhere, and those lymph nodes will go away as the bones heal. So I had a woman come to me about 15 years ago now, who, just like her, newly diagnosed breast cancer, and it's wrapped around her heart, her pericardium, which is very bad because she got short of breath all the time, and she had a big pericardial effusion. So we started her on treatment. At that time, it was chemotherapy. It went away. She went into complete remission. She comes back to me about 3 years later and says, "Now, when are you going to remove my breast?" I said, "But there is no more disease in the breast either." And so, see, that she was thinking again, but it's breast cancer. You got to remove my breast. She lived, I don't remember, she lived a long time. I mean, she lived so long that we didn't follow her up anymore. She was followed up at home. And as far as I know, she's still alive. So that's the same situation. Once you have metastatic disease, it's not like it's unimportant. If it were pressing on nerves and causing you where you couldn't use your hand or your arm, we would certainly give a lot of attention to it, either surgery or radiation right now. But because it's not a unique problem causing a problem in that area, you're on systemic treatment. So the analogy I could use there is not everybody that has a sore throat has their tonsils removed. If they take an antibiotic and the tonsillitis goes away, they just leave the tonsils in. Now, after about 5 or 6 episodes of tonsillitis, probably the tonsils will come out. So that is not a bad question. Are there stage 4 people that do so well that the lymph nodes or even the breast lump is the only remaining site of their disease? And that's a debate we've had for about 30 years, 40 years. Do you do surgery on those people or not? And there has to be some period of time where the answer is yes, because the last thing we'd want to happen is for you to go through breast cancer surgery and the lymph nodes removed and maybe get some lymphedema and the bones act up again right after that. We'd have done all that for no reason. So it's the whole picture that matters, not any given spot. Now, having said that, we do rank some spots over others. Your brain's pretty high on that list. Your lungs and your liver are pretty high on that list. Heart, but that's rare. Because you breathe, metabolize, and think with those organs. Bones are important. They hurt as you experience. But you aren't going to die of bone disease. You don't live with your bones. You just suffer with them. And don't fall and break one, because that causes a lot of problems.
More.
So lymph nodes are way down on that list, and a breast lump is even further down because it's not affecting your life right now.
Okay.
Now, having said that, none of this is really affecting your life right now as far as expectation of how long. None of the organs we know this is in are in immediate threat to your life.
Okay.
We just don't want them to get that way. So that's why, like I said, that's not an uncommon question. What do you do with the primary sites in people that already have metastases? And sometimes we do go in and remove those. I'm not sure why. I'm working on a different problem here. I put my name up here. There we go. I didn't click the add up it. And it's supposed to show up there. I didn't add my name. So I got to the voluntary request. Who knows? So Dr. Walters, as my physician and such associates, technical assistants, and other healthcare providers as they may deem necessary to treat my condition, which is breast cancer. I understand the following chemo treatment has been planned for me, and I voluntarily consent and authorize these treatments. And it's palbociclib, that's the generic name. It is a cancer-fighting medicine that is taken by mouth.
Okay.
This targeted therapy fights cancer. Its purpose is to inhibit cell growth, the actual cell cycle, by preventing cells from progressing through their cycle. I haven't read this often enough to realize I got to hit myself there. I understand the physician may discover other or different conditions which require additional or different treatments than those planned. I authorize my physician. That's in you. That's like pain. I authorize my physicians, such associates, and technical assistants and other healthcare providers to perform such other treatments which are advisable in their professional judgment. I understand this. Well, I understand this treatment may involve unforeseeable risk to the embryo fetus. That's very unlikely.
Yes.
That would be a
God
Ripley's
forbid.
Believe It or Not.
Yeah.
Don't have to worry about birth control there.
Yeah.
I understand, and this is important in the field of medicine, I understand no warranty or guarantee to me has been made as a result of cure. That's what we're shooting for. That's why we're oncologists, but we can't guarantee it.
Right.
Just as there are risks and hazards in continuing my present condition without treatment, there are also risks and hazards related to the performance of the treatment plan for me. And here's what it can do. So this is where it starts to sound like chemotherapy. Low white count, infection, fatigue, low red count, nausea, vomiting, or appetite loss, mouth ulcers, hair thinning, diarrhea, low platelet count, muscle weakness, and rare respiratory symptoms include. That reads like a lot of our chemotherapy consents. In fact, I think that section is pretty much copy and paste from a lot of them.
Okay.
Now, Ibrance is not like chemotherapy, like I told you, but it affects the cell division of all cells in your body. That's why sometimes your blood counts do go down, and that's why we monitor how you do on the treatments. What you don't see here, you don't see heart damage, liver damage. I mean, you don't see a lot of things on this list that would be on most of our chemo lists.
Okay.
I've been given an opportunity to ask questions about medicational alternative forms of anesthesia, sedation, treatment, and this of non-treatment, the treatments to be used, the risk and hazards involved, and I believe that we have sufficient information to give this consent. I certify this form has been fully explained to me and that we have read it or had it read to me and that blank spaces have been filled in and I understand its contents. Is this page be assigned by you? Yes.
Yes.
And then what you do is you go to this little machine over here.
Can you get up?
Well,
Wait.
Wait,
I got it,
I
I got
told
it,
you
I got it.
not to break that yet. We really don't want you to break that hip. Sign by device. There we go. Now you can go.
So, her hormone therapy, since she says it was due, the next one's due on August the 11th, is that something that you're gonna continue?
Yeah.
You
You mean the refills?
it was actually IV infusion.
That's the Zometa. Okay, let me explain Zometa. I'm not seeing this. Just a second. Just a second. Okay, now do it. There we go. Zometa doesn't kill off a single breast cancer cell. In fact, it's actually a drug that started out kind of in osteoporosis world. It's a bone healing drug. So the reason we use that is that it speeds up in the healing of bones when the cancer cells get cleared from them. But it's not a chemotherapy drug and it doesn't affect cancer.
Right.
So yes, we would continue the Zometa for, we argue about this too, at least a year.
Okay.
And its effect also depends on how well the other treatments are working.
Okay. Very good.
So Wednesday, you said?
August 11th was the due date.
It's my due date, yeah.
We can do that. So we call that a treatment plan. And
It's
then I'll
August the
do
11th,
here, and then I'll give you a copy of this.
Okay.
Oh, I can use this one. I need this one.
You want me to help?
No, this is gonna be my appointment, but.
Very nice. Good job of staying organized.
And actually, the paragraph that's not in there, now that I think about it, there's a paragraph in most of these, and I'm surprised it didn't come up in mine. I don't think I skipped over. You can always withdraw your consent at any time, and it will not be held against you in any way. So you're a person. You can change your mind anytime you want to. I know. But that's always true. You're the boss. We're just your advisors with an MD degree. But that's it. We're your advisors and you get to make the choices.
You work together in this role.
Yep, that's right. That is right. So now I can do this. So now what I will do is let's see. I have to order the medicines. So I'll make sure your script to Blue Cross, and that is over here.
Do I need to call Blue Cross Blue Shield and let them know I'm no longer with the Austin Cancer Center? And
I don't think so. They usually don't care what.
No.
I mean, Walmart.
yes,
So you have Walmart, but you don't have the Blue Cross pharmacy in here.
No.
You get them, yeah, this is what I told you, you don't wanna do that. So you must
Never
have,
used it.
you must have,
I've never used it. It's available to us.
you can tell how many medicines I
Oh, I was supposed to give that to the nurse.
it used to be, Express Scripts. So we have Express Scripts, is that it?
I've never used it. I know we have it, cause it's available to us, but I've never subscribed to
Okay.
it.
All right, so we gotta make sure that they don't know you, in other words.
Yes, they
Right.
don't.
But you're a member of Blue Cross,
Yes.
so, yeah.
Yes, that is available to us.
So I think that means if I type in here Express Scripts, trust me, you do not want to be buying this medicine.
Okay.
Home delivery, St. Louis, yeah, for Hanley Road, okay. Okay, that now is at least, these are all the things that I kind of know how to do, but I don't do them as often as other people do. Normally, I would go out the door, and then a host of people would start showing up to do the consent, to make sure everything is there and so on. All right. So now go over here. Treatment plan 1 is going to be here.
Are you trying to call? No, accidentally.
Palbociclib and aromatase inhibitor. Starting, well,
ASAP.
we'll say the 13th. I mean, line of treatment. Frontline metastatic. Treatment goal. As much as I want to click curative, but we wrote this life prolongation certainly greater than a year, okay? Just because it's metastatic. We really want curative,
Yes.
yes. Okay, so
Yeah, we
that's
haven't
set
heard
up.
that word.
And now treatment plan 2, see there's that, this is how Epic does our order sets and everything, so I gotta go back in, and then I'll make sure that's ordered, and then we'll set that up to be ordered. And then I want another treatment plan, which is going to be Zomita.
Did you hear what he said? We want it cured. That was never told to you. They said you are totally incurable and needed palliative care.
Yeah, so doctors are,
I'm trying to give you a little more hope, a little more vision, no tunnel vision.
so, doctors are actually measured nowadays about whether they mention the worst possible circumstance that could happen. And that's just kind of the way the world is going in measurement. You know, did we discuss your goals of care? Did we discuss your advanced care planning and all those things? You're right, it's kind of pessimistic, especially for a person who's just starting treatments. I don't do that explicitly. we've talked about it. It's a serious situation. It has to get better, and if it gets better, it can stay better for a long time. That's kind of it, and we're like you. We wait to see what happens. Okay, there we go. So now both the So I set up the Zomita for next Friday because you come and see me on Fridays. I have been through that
Okay.
world where you're here like 5 days a week and so on. I'm here on Fridays, but I'm here all day on Fridays. It's psychologically not bad because I come in at 7:30 and I don't leave until I'm done. And you're prepared for it, whereas other days get to be crazy if you come in without that preparation. So I set the Zomita up for Friday.
Okay.
The Ibrance is going to have to go through your pharmacy, your mail out pharmacy at
Okay.
at Walgreens. I mean at Blue Cross, and so I set that up for Express Scripts.
Okay. Perfect.
Your Arimidex, I'll order that and put refills on it, but you might probably already have a couple refills anyway. That can go through Express Scripts too if you want.
Okay.
I mean, it might as well take
Might as
advantage.
well take advantage of
Might
it.
as well.
Good idea.
And all that I'll do in just a little bit because we got
Sure.
through the important part. But what I do need to get for you now is a copy of the consent form that you signed, and then a copy of our information sheet about palbociclib.
Okay.
It just about repeats a lot of the things that were in the consent form, fortunately, but so that you kind of know what you're getting into.
Okay.
You take it for 21 days, like I said, and then you rest for 7 days. And on the 28th day, you come back, and then we see what your counts did, whether you're ready for the next cycle, what problems you had. Very commonly, none.
Okay.
And then we start the next cycle
Okay.
with any dose adjustments that are needed. So it's not a very complicated treatment. It's actually one you're giving yourself, and I'll be doing it I don't expect if I mail out that prescription today, I don't expect you'll probably get it till next week.
Okay.
So that's why I started everything on a Friday. Now, in the meantime, you can just continue your Arimidex because that's treatment anyway, and it doesn't have to go through any of that rigmarole.
Okay.
So definitely you're on treatment, continue that treatment as we work in the addition of this other treatment.
Okay.
And continue the other treatments you're on in Zomita.
Okay. Sounds good.
So do we need a baseline today for labs?
Probably add that on for next week.
Okay,
I don't need it
perfect.
today. Oh, and I'm gonna set up the pain consult too. Yes, I will set up the pain consult and ask for it soon.
And
So
do I have a-
pain is like somewhere in
Somewhere,
somewhere here, yeah.
Is there a certain time I need to be here for the Zomita?
That'll all be, so I just put I didn't sign the order, I
Just
entered the
put-
order
okay,
set.
okay.
And then once I sign that a little bit later on, that's when
That's when I'll-
you start getting things in my chart and it says.
Perfect.
Be here then and so on,
Right, appointments and things of
Okay.
that nature.
including the blood tests.
Okay. Oh,
Perfect.
great.
Again, that's why I took you to the national guidelines. You're getting right down the middle, best known treatment, FDA approved, all that stuff. You're not, this is not the time to go to research, and I don't think it's the time to jump into chemotherapy.
Okay.
Believe me, it's kind of dangling out there just in case.
So what
So the
about-
foreign body port, it's okay for right now,
Yeah, I was.
or do we take that out?
I would. They'll use it for the Zomita anyway.
Okay.
They'll be glad it's there for the Zomita.
Okay,
Oh, good.
perfect. There you
Yeah,
go.
I
Good
thought
came-
about that. 'Cause
good
I
came
said,
from it.
You know, only a pessimist would have put a port in you, but the port's still good for the Zomita.
There you
Okay.
go.
Perfect.
Yeah. That thought crossed my mind though, whether to have that removed. obviously not.
Yeah.
Okay, then we'll use that for that.
Clear as mud?
Clear as mud. Yes,
Very clear.
absolutely.
A
Better
lot-
mud than what we could eat this mud and digest
Yes.
this mud.
A lot easier.
We can make patty cakes with this one.
We're pretty good at responding to my chart. I see them. Use that liberally. Well, use that liberally, but not enough. You make the nurse angry. My nurse isn't here today, Alicia. But no, she's very good at responding to those. And I can't think of anything else you need today.
Okay.
You can, and we're going to try to make some adjustments in your pain medicine. I guarantee that.
Oh, good. 'Cause that's with the new med, I can actually work. Because right now with the pain, it's hard. I've been doing when I can. Is sitting down on this left side is what, even with the patch, and at the end of the day, my body just hurts so bad. I just want to lay down, get off my feet. I just want to sleep. I just want to take something just to give me that.
Yeah, and I hear you. So on the balance bar between being obtunded and can't think and pain relief, you're close to the middle, but it kind of be tweaked one direction a little bit, maybe towards the pain relief side. She said you're probably not someone that we would trust driving a car.
Oh, that's good. Yeah.
But as you said, you can work, and
Yeah,
we
my
don't.
husband can take me to work, and I know that would be. I don't like being at home, and
Yeah.
because that's what They just told me to slowly build up, so I've been trying to work for at least 3 to 4 hours, but that 3 to 4 hours is a lot, but I can do it. It's just at the end of the day, when I'm off my feet, my body, it's just.
Yeah, she has nothing more to give but to go to bed.
Well, I admire you going to work, because
I
there are
don't.
people like you. Say, well, I worked for a long time. Let me take my disability and ride that
No.
as long as I
Mm.
can, and
No.
yeah.
I'm not doing disability.
Yeah,
No.
No.
That's not life.
No, that is not life.
Right.
Okay, I'll stay here till we get you some more paperwork, and then you can take off. I can't think of anything else.
Perfect. Thank you so much.
You're
So
the
before
boss.
you exit, yes, it's really good. So your prognosis for right now versus what
Well,
we had.
So she doesn't have any life-threatening disease. This is gonna really make you think. Your 3-month prognosis is very good. In fact, I would be shocked if you were sick 3 months from now, sicker than now. Your 6-month prognosis is good. I mean, I think your 1-year prognosis is good. I also think your 2 and 3-year prognosis is pretty good.
Okay.
My crystal ball gets very fuzzy past that. But the reason this is our frontline treatment is because people are alive 5
Mhm.
years and 10 years, because Arimidex has been out that long. Palbo has not. There are people around. Are they disease free? Many of them are not, but some are. And so there is hope. There
Okay.
really is hope. And I will have that talk about advanced care planning and codes and all that stuff when the lung's overwhelmed, or when the liver's not working,
Okay.
or when your brain's a problem.
Okay.
You're not that. You're not that.
No.
No.
Not about.
Because we are measured on when we have that talk, and unfortunately in oncology, a lot of times it's when a person ends up in the ICU. And that's the wrong time. But this is also the wrong time.
Yes.
You understand the goals of care. So if I had to,
Yes.
goals of care right now are to treat the disease, result in improvement, and control it for as long as possible, and that could be years.
Yes.
And I'm not lying. Actually, they give some of the reference, but even a search on any journal articles about aromatase inhibitors and Palbociclib for metastatic breast cancer. Yeah, it's the average is in a few year, couple to few years,
Yes.
which is exactly what the television ad says. They can't make up information.
Great. Well, thank you.
Okay, you can get dressed though. Don't fall.
Yes.
Please don't fall.